Now we are starting our internal medicine lectures. First, we will discuss about acute coronary syndrome or ACS. ACS is acute coronary syndrome. When patient present with acute chest pain or something acute chest pain, we will consider it is a critical diagnosis for acute coronary syndrome. It is caused by sudden decrease in coronary blood flow, for example, cardiac ischemia. Decrease coronary blood flow it can lead to cardiac ischemia. Rupture or erosion of atherosclerotic plaque, it causes thrombosis. It can lead to thrombosis. There are three types of acute coronary syndrome. We have discussed that patient with acute coronary syndrome present with severe chest pain, and there are three types of acute coronary syndrome. One is ST elevation myocardial infarction or STEMI. Other type is non-ST elevation myocardial infarction or NSTEMI, and third is unstable angina. These are three types of acute coronary syndrome. If patient is presented with acute chest pain, we will suspect acute coronary syndrome, and we will assess if patient is stable or unstable. We will do ABCDE assessment. This assessment is done to see if patient is stable or unstable. This is airway, breathing, circulation, disability, and exposure. And if patient is unstable, for unstable patient, we will stabilize airway, breathing, and circulation. For this patient, we will stabilize airway, breathing, and circulation. And after that, we will obtain IV access. Vital monitoring. Cardiac telemetry. And we will make sure defibrillator is available and its pads are intact. We have discussed about management of unstable patient. Now we will manage the stable patient. First, we will do focused history and physical examination of stable patient. Focused history and physical examination of the stable patient. History, he was presented with pain and pressure and tightness, discomfort, pain and tightness in the chest. Pain may radiate to left neck or even jaw. This pain can radiate due to acute cardiac ischemia. It is worse with exertion, does not go away with rest, and does not change with movement or position. Along with chest pain, individuals can complain of shortness of breath, sweating, epigastric pain, and nausea. During the history taking, we will look for main risk factor for heart conditions. These risk factors are hypertension or high blood pressure, diabetes mellitus, hyperlipidemia, obesity, tobacco use, and family history of coronary artery disease. Physical examination may be normal. Physical examination, we can see dyspnea or shortness of breath. We can see tachycardia or very high heart rate. We can see diaphoresis or excessive sweating. The physical examination findings can also be very different with extent of injury in the heart muscle. When there is injury to the papillary muscle, it can show with mitral regurgitation, new systolic murmur, jugular venous distension, hepatomegaly, lung crackles and lower extremity edema. After detailed focused history and physical examination, we will suspect acute coronary syndrome, ACS or acute coronary syndrome. Then we will immediately do 12 lead ECG and we will send labs of cardiac troponin. We will do immediately 12 lead ECG and cardiac troponin. We will order cardiac troponin labs. Cardiac troponin is basically serum marker of myocardial injury. This cardiac troponin. We will obtain ECG within 10 minutes and we will not delay it because it is very urgent and very necessary in the when we will suspect acute coronary syndrome and chest pain. When we do 12 lead ECG, then we will start initial management. We will be starting initial management of acute coronary syndrome. We will obtain IV access. Continuous vital monitoring of the patient. And we will provide supplemental oxygen. So we can keep oxygen saturation level more than 90%. It is very necessary in the initial management. In the initial management, we will start high dose aspirin. We will start high dose aspirin to inhibit platelet aggregation. We will do sublingual nitroglycerin. Sublingual nitroglycerin basically improves coronary blood flow and relieves chest pain. We will provide high intensity statin. So it stabilizes plaque impairing and blood flow. It stabilizes blood flow. We will give beta blockers. If chest pain persists after this treatment, we will give IV morphine. When we will obtain ECG results, then we will identify its ST elevation myocardial infarction or non-ST elevation myocardial infarction. If ST segment is elevated in two contiguous leads, then it will be ST elevation myocardial infarction. ST elevation in more than two contiguous leads, and when left bundle branch block, it can mask ST elevation. This left bundle branch block, it can mask ST elevation, and its QRS duration is more than 120 millisecond, and it has broad R wave. Its diagnosis can be made by left bundle branch block and presentation strongly suggestive of myocardial infarction, MI. So we will cardiac troponin level will be increased, but they are still not available because we are initially managing by obtaining ECG and initial management. So ECG is enough for further management of this patient. Now we have identified with the help of ECG that it is ST elevation myocardial infarction, and now we will start medical therapy. So we will do dual antiplatelet therapy, that is DAPT, dual antiplatelet therapy, or oral P2Y12 inhibitor. So these P2Y12 inhibitors are clopidogrel or ticagrelor and aspirin. Clopidogrel plus aspirin. And we will start parenteral anticoagulants that will decrease risk of further thrombosis. Parenteral anticoagulant, it will decrease risk of further thrombosis, and we will administer these medications promptly, but we will never delay reperfusion therapy, because reperfusion therapy is very necessary in acute coronary syndrome. We will do percutaneous coronary intervention or PCI, percutaneous coronary intervention, and fibrinolytic therapy. Percutaneous intervention is preferred strategy in this situation, but PCI cannot be used in all patients, and presentation is key factor. Now we will assess time of symptom onset, and we will determine which treatment can be used in this case. Now we will assess time of symptom onset. If it is less than 12 hours since symptoms onset, less than 12 hours since symptoms onset, we will assess PCI availability, current location, or by transfer. If PCI is available less than 120 minutes, percutaneous intervention is available, then we will do emergent coronary angiography and PCI. The first, we will insert catheter in radial or femoral artery. Insert the catheter in radial or femoral artery. Then we thread it up to coronary arteries. Then we will advance balloon tipped catheter and we will inflate this balloon and place the stent. We will inflate the balloon and we will place the stent. If PCI is not available in less than 120 minutes, we will do fibrinolytic within 30 minutes of patient arrival. We will start fibrinolytics therapy within 30 minutes of patient arrival. So these medication that dissolve blood clots, these fibrinolytics are very important medication to dissolve blood clots in coronary arteries, but these are contraindicated if there is severe bleeding, active bleeding, recent stroke, significant head trauma. So these fibrinolytics are contraindicated. We will provide fibrinolytics and transfer to PCI capable center. Patient will be transferred to PCI capable center. If more than 12 hours are passed since symptoms onset, then fibrinolytic therapy cannot work, because fibrinolytic therapy is only effective in first 12 hours. We cannot do fibrinolytics therapy if more than 12 hours have passed. In this case, this is not option. Now there are more than 12 hours since symptoms onset. Now we will assess for ongoing ischemia complications like refractory chest pain, hemodynamic instability, dynamic ECG changes, arrhythmias and heart failure. If these symptoms, refractory chest pain, hemodynamic instability, ECG changes, arrhythmias and heart failure are present, then we will do emergent coronary angiography and PCI. We will do emergent. Or if these are absent, then we will continue current medical therapy and arrange for follow-up coronary angiography and PCI. Now we will discuss about non-ST elevated myocardial infarction or non-ST elevation acute coronary syndrome ACS. We will see on ECG ST depression and T wave inversion. These are signs of non-ST elevation myocardial infarction. In non-ST elevation myocardial infarction or non-ST elevation acute coronary syndrome, now we will assess cardiac troponin levels. These cardiac troponin levels are very important. If cardiac troponin levels are elevated, so it is non-ST elevation myocardial infarction. If cardiac troponins are elevated, and if cardiac troponin level is normal, then it is unstable angina. Unstable angina can also cause very severe chest pain. So these two, NSTEMI, non-ST elevation myocardial infarction, and unstable angina. Now we will start medical therapy of NSTEMI and unstable angina. In medical therapy, we will start with oral P2Y12 inhibitor. This is dual antiplatelet therapy. So in P2Y12 we have clopidogrel, ticagrelor, and we will also provide aspirin, and we will give parenteral anticoagulation therapy. And then we will assess for ongoing ischemia complications. We will assess for ongoing ischemia and complications. If ischemia and other complications are present, then we will start emergency coronary angiography. We will start emergency coronary angiography. So we will do immediate PCI. And we will start coronary artery bypass graft surgery or CABG. Coronary artery bypass graft surgery. We will do PCI or coronary artery bypass graft surgery. So main indications for CABG are it is 3 vessel involvement, left main coronary artery disease, and it has better outcomes than PCI. Now we will assess for ongoing ischemia complications, and if these are absent, then we will stratify risk. And thrombosis in myocardial infarction score or TIMI. In absent ongoing ischemia, it is absent, then we will stratify risk by TIMI. TIMI is thrombosis in myocardial infarction score, and we will start GRACE. GRACE is Global Registry of Acute Coronary Events. Global Registry of Acute Coronary Events. We will assess and stratify risk factor by these two scores. If high risk, we will start PCI within 24 hours. If patient has low risk patient, we will start a non-invasive stress test or coronary CTA. If it is abnormal, then we will do CABG, cabbage therapy, coronary artery bypass, or PCI. If it is abnormal, and if it is normal, then we will continue current medical therapy. We will repeat serial ECGs and troponin measures in patients, and if in ECG we will see ST elevation in 2+ contiguous leads and new left bundle branch block with strong clinical suspicion for MI, then we will suspect of ST elevation, myocardial infarction. Now we will start medical management of ST elevation, myocardial infarction, or STEMI. We will provide additional antiplatelet medication. Antiplatelet medications. And we will start anticoagulation therapy. So in emergency reperfusion therapy, we will start PCI and fibrinolytic therapy, and troponin level will also increase in this situation. Now we will see about ECG findings and troponin levels in unstable angina and NSTEMI. If ECG shows ST depression and T wave inversion, but troponin level is increased, then it will be NSTEMI, non-ST elevation myocardial infarction. And if troponin level is same and in ECG ST depression is showing and T wave inversion is present, then it will be unstable angina. Unstable angina with normal troponin levels. For medical management of NSTEMI and unstable angina, we will start additional antiplatelet medications, anticoagulation therapy, and schedule coronary angiography, revascularization, PCI, and coronary artery bypass graft, CABG. If ECG is normal and troponin level is also normal, these are normal, then we will assume it is coronary artery disease or CAD. Then we will provide lifestyle modifications guidance, low dose daily aspirin levels, coronary angiography we will provide, or we will provide if it continues these conditions, then we will provide PCI or CABG.